Hello, one and all. So looking forward to this session together. We've got 3 more minutes till we hit the top of the hour, and then we will start with the broadcast. And so I want to welcome you here today. We have Stephanie Austin on for our support person, and I'm Dr. Margaret Fitzgerald, founder of Fitzgerald Health Education Associates, and I'll be on today as your content expert. So we're going to give it a couple more minutes, but in the meantime, since we have a few people who are here a little ahead of time, I want to bring your attention to something that you'll find on, well, the way it comes up on my Zoom is the top bar, control bar. For me, it's on the top of my screen. And if you look way, way, way over to the right, you'll see a circle with 3 dots in it. And underneath it, it says more. That if you click on that, you're going to find the Q&A box. And so questions to me during the program go in the Q&A box. And then if you have a technical question for Stephanie, that can go into the chat. And think of, while we're getting ready, again, just so that you know, I'm going to repeat all of this when at the top of the hour. But anything that seems to be kind of sort of getting in your way of getting ready for your boards. Think of anything along those lines, and try to make it as narrowly focused as possible. So not like I don't understand anemia, but I'm having a difficult time between microcytic and macrocytic anemias, something more specific like that. And I am happy to help you out on this. So we'll get going in 1 more minute. 1 more minute. And for those of you who just arrived, we're just waiting for the clock to go to the very top of the hour, and then we will get going. Okay, it is the top of the hour. Welcome to the session on Ask and Apply Live Exam Strategy. I'm Dr. Margaret Fitzgerald. I'm the founder of Fitzgerald Health Education Associates. My clinical practice has been as a family nurse practitioner in family-centered primary care in a federally qualified health center in a small city about 30 miles north of Boston. And I have been privileged to practice there for more than 3.5 centuries. And I've even followed some of the same patients for 3.5. Did I say centuries? I mean decades. Yes, I'm older. I'm not that old. 3.5 decades, where I actually have followed some families for that entire period of time. It's been a great privilege to do this work. I'm also on faculty at Case Western Reserve University in Cleveland, Ohio, which is where I did my doctoral studies. In fact, I just did some teaching for them out in California. And I sit on the Pharmacy and Therapeutics Committee of a large HMO based out of Boston, Mass General Brigham Health Plan, and I do about 45 other things. So for those of you who have been with other sessions, you'll always hear me say this, and you might say, yeah, we know all of this already. But one of the things I want to remind you is right now, since all of you are getting ready for your NP boards, it might seem like, why in God's name am I even bothering to do this? And what I want to do is let you see, yes, I've had a long career. But on the other hand, this is going to be one of the best. This is going to be not one of the best. This is going to be the best move you've ever made in your healthcare career, is becoming a nurse practitioner. Okay. What's the purpose of these sessions? It's to support your success we at Fitzgerald Health are all about your success. We have helped about 180,000 nurse practitioners to date successfully become certified. And some of our best work has been with people who have struggled mightily to pass boards. And so we're going to be looking at you answering your questions in real time and your concerns as you prepare for your boards. But also, and this is probably the most important part, I want to drill into your noggins today. Expand and secure your knowledge base, hone your clinical decision-making skills. Right now, you have to trust me on what I say. You're already a good test taker, because a lot of times what NP review says starts off with saying to you, you're anxious, you're a rotten test taker. We'll see if we can help work around those things. No. Anxious, yes, that's a normative response to a high stakes exam like this. And the other thing is, let's face it, nobody made you become a nurse practitioner, did they? It's not like jury duty that you couldn't get out of it. So you made that decision. I want to remind you why you made that decision. Only 11% of all RNs go on to become nurse practitioners, 11%. So you are in very rarefied air here, very rarefied air. But part of this is to remind you to get to this point where you have at bare minimum a master's degree. And many of you have more than one master's or a postmaster's certificate or a doctoral degree or a postdoctoral degree. What you need to remember is you are an experienced test taker. You are not a poor test taker. If you were truly had some major issue that got in the way of your ability to sit for a high stakes exam, you wouldn't be in this session today, because you would have been unable to achieve this level of success. But here's the thing. The boards are all about securing, about showing that you will be a safe and effective clinical decision maker as an entry level NP. And I hope everybody has that. And that's another thing, is I repeat that pretty much every session, because people don't come in for all of these sessions. They come in and out. So reminder during these sessions, questions to me, clinical and exam content, go into the Q&A box. And if you're saying, where the heck is the Q&A box? Go to your control panel. The way it shows up on my version of Zoom is it's at the top of my screen. And if you look all the way over to the right, there's a little circle with 3 dots in it. Click on that and the Q&A box will show up. The only person who sees what's in the Q&A box is me. That's it, okay? If you have a technical or a support question, go to the chat and Stephanie will be able to help you out, all right? So the way these sessions go, and this is important to consider here, is I will do some prepared comments and then I'll take your questions. So I'll do maybe 20, 25 minutes of prepared comments. And what I want you folks to do at the same time is start putting your questions while I'm speaking into the Q&A. And then that way we'll be off and running. Points to consider when getting ready for the NP boards. The NP boards bear 0.0 resemblance to the NCLEX exam. You know, with the NCLEX exam, and I know probably most of you took the old NCLEX and not the next gen NCLEX, just because the next gen NCLEX hasn't been around that long. But you know, when you sit down for the boards, you don't know how many questions you're going to get. Well, it's going to be anywhere between 75 and could be north of 200. And for those of you who might have sat for RN exam, the NCLEX exam during COVID, you might have only needed to take a minimum of 65 questions. That's not the way the boards are. The number of questions you answer on the boards was predetermined ahead of the test. You will answer on AANP. You will answer 150 questions. 135 of those count towards your final score. 15 are in there for test, retest, validity, reliability, the whole psychometrics business. and you have 3 hours. With ANCC, you will answer 175 questions. You have 3.5 hours, and 25 of those questions are in there for test, retest, validity, and reliability. So long and short, either exam, you'll answer about 135, if you will, exam room questions that count towards your final score. By the way, those questions that are in there for psychometric testing, they're woven throughout the test, and you will not be able to tell which is which. So you treat every question like it counts towards your final score. You can highlight questions and go back to them later. This is what I recommend you do. Highlight the question, answer it on. So if you're struggling with a question, go highlight it, answer it, go back to it later. If you never get back to it, you at least have that 1 in 4 possibility that you got it right, okay, by sheer luck. But chances are what happened was you got down to those 2 options that look plausible, but one is the better of the two answers. So you have a bare minimum of 50-50 chance of getting it correct, okay? And please plan on using all or nearly all of the allotted time on the test to analyze and synthesize the information in each question to find that best, not just correct answer. And where do you find the difference between the best and not just a correct answer? It's in the story of the question. It's in the stem. Every word in the stem, the story of the question, is what's going to lean you one way or another, okay? You want to study with purpose, intent, and goals. You need a well-developed study plan that enhances the knowledge base and sharpens your clinical decision-making skills. You cannot practice question your way through the boards. When I do counseling every month for people who have failed boards, and invariably what they say to me is, I did 2,000 questions, 5,000 questions. How could I have failed boards? Well, then I'll say, what did you do to hone your clinical decision making? What did you do to secure your clinical knowledge base? And they'll say, I did 5,000 practice questions. I said, no, that's not how you get through boards. You need to know the how, the what, and the why of clinical practice. And if you're wondering what that is, all of you have access to the Fitzgerald review course. The most important chapter of that review course is the first chapter. So go back to that if you haven't done the course yet, and you will get an idea of what that how, what, and why of practice is. So what you want to focus your study on the following, because these are the components of clinical practice, and these are also the exam domains. So assessment. Assessment will be roughly 20-25% of the exam. So one way of thinking of that is that's 1 question in 4 will be assessment. So that is gathering subjective, objective information. So history taking skills. I wrote a best-selling AJN Book of the Year award-winning review book. I want you all to buy it because it's a great product. It's the 7th edition. Make sure you get the 7th edition of the Fitzgerald review book. We sell it at FHEA, or you can get it on Amazon. Yes, my book will be incredibly helpful for you, but here's the other thing. Sometimes what you need to do is go back to basics. Somewhere in your book or your Kindle or your whatever archives, you've got a health assessment text that you used early in your NP program. I'm assuming all of you are more late in your NP program, okay? And Bates, Seidel, Jarvis, whatever it is. And there is a chapter in there on gathering data. It might be assessment, it might be talked about as history taking. Read that over. you know most of that information, but one of the things I want you to do is go over when to use open and close-ended questions and interviewing techniques that demonstrate cultural competency. Now, remember issues with cultural competency. We live in a multi-ethnic, multicultural nation. We do. You might say, well, when looking around where I live, it's not that multicultural. Okay, but the nation as a whole, it's one of our strengths, is a multicultural nation. We can't know every single culture. We can't. It's impossible. It is impossible. So do not think that you're going to be asked about super specific things about a given culture, because we can't know all of these. I happen to practice in a predominantly Dominican community. So therefore, I'm practicing in a community where I am not a member of that community. And I've learned a lot about folk practices, cultural beliefs, things along those lines. I'm always learning something new. Always learning something new. So, but one of the things is with cultural competency, think more generality than specific, because remember, this is a national exam. If like Eastern Massachusetts, where I practice, happens to have one of the largest Haitian communities in the United States, one of the largest Brazilian populations, a lot of African Caribbean nations are represented, but then there are about a bazillion other people too. We couldn't know all of them. Plus, if I were sitting for the boards again, the boards are not going to customize my exam to where I currently live. No, it's a national exam, Okay. So let me give you an example of open and close-ended questions. And sometimes this is the thing that you'll hear from somebody who took boards will say, oh, there were these psychosocial questions on boards. Well, of course there are. That's part of our practice. But this gives you an idea of an open versus a close-ended question. A 58-year-old woman presents for follow-up on hypertension, dyslipidemia, and type 2 diabetes. Her blood pressure and A1C are at goal. So do you notice you're not given the numbers, but you're told she's at goal. So we're moving on from this. Her current meds include lisinopril, 40 milligrams PO daily, clothalidone, 25 milligrams PO daily, atorvastatin, 40 milligrams PO daily, metformin XL, that's the extended release. FYI, only prescribe the extended release metformin, a lot easier on the gut, 2 grams daily, and canagliflozin, 100 milligrams PO daily. Now, I teach pharmacology. I've been in practice forever. I recognize that what she's on is optimized doses of all of those meds, all of them, okay? And you will not be asked about drug doses. You will not, your next question will never be, are all those doses optimized? No. But I recognize that because I'm an experienced clinician. Here is another way that same beginning of the question, the stem, the story of the question might be presented. A 58-year-old woman presents for follow-up on hypertension, dyslipidemia, and type 2 diabetes. Her blood pressure and A1C are at goal. Current meds include an ACE inhibitor, thiazide diuretic, high potency statin, metformin, and an SGLT2I. Okay, so what was the difference? This one told you each med. Okay, this one referred to the drug classes. There is an expectation that you would be able to recognize this either way. And by the way, in the next session, 2 weeks from today, same time, I will go over identifying some drug classes if you're struggling with this. This one is simply referring to things in their drug classes, okay? When conducting a medication review, the patient mentions, quote, I do a pretty good job of taking my meds most days. Okay, there's a little alarm here. Pretty good most days. So what the key is here, and a lot of times people will say to me, I didn't even know where to start with this question. No, 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 you know where to start. She's giving you a hint that maybe some days she has a hard time remembering to take her meds, something gets in her way. Maybe it could be finances where these meds are. I'm going to go back a slide here. Okay, ACE inhibitor cheap, thiazide diuretic cheap, statin cheap, metformin cheap, SGLT2I not cheap. These are all branded drugs, so they are expensive. They are expensive. And so which of the following is the NP's best response? Best response. A, are you missing doses because of side effects? B, do you ever forget to take your medication? C, tell me how you take your medication on a typical day. D, how many days have you missed your medication in the past month? All right. So this is, you know what this is, folks? This is NUR 101. All right. Run through this. Are you missing doses because of side effects? Well, what's that? That's a closed-ended question. Yes or no? B, do you ever forget to take your meds? Again, yes or no? C, tell me how you take your medications on a typical day. Open-ended. You will always, always, always gather more information from an open-ended question than you will do closed-ended. So here, C is the best response. And then D, how many days have you missed your med in the past month? One more time, closed-ended question. So C is the best answer. Truth be told, you might ask all four of those questions during the clinical encounter. But what's the key here? The NP's best next response. Let her tell you how she's doing. Because one of the things you'll notice is this woman's on a bunch of different meds. The more meds people are on, the higher the rate of non-adherence. We don't use the term non-compliance, non-adherence, okay? So higher rate of non-adherence to therapy. So I'm sorry, it looks like I forgot to highlight the correct answer here, but C is the correct answer. Tell me how you take your medication in a typical day. She might be splitting these meds up into like 4 or 5 times a day. The more times people take meds, the more likely they are to forget. But again, I'm going to go back for a moment here. ACE inhibitor once a day, thiazide diuretic once a day, high potency statin once a day, metformin when you do the extended release formulation once a day, SGLT2I once a day. She can take that ACE inhibitor, thiazide diuretic, the statin, and the SGLT2I all together when she first gets up in the morning on an empty stomach. They tend to be very easy on the stomach. Now, the metformin's a little different. Metformin is best taken with the largest meal of the day, okay? Some people, I have some patients who take their metformin on an empty stomach, they're fine. I have other people who take it on an empty stomach and they immediately get lower abdominal cramping. So, you go with what the patient has to say, but try to limit the number of times a day a human being needs to take meds. They're going to do a lot better with them from a viewpoint of adherence, okay? So C, okay. Hold on, sorry about that. I'm going backwards instead of forwards. All right, so C, the best answer here. Assessment, symptom analysis. If you do not have this, well, first of all, let me backtrack for a second. One of the most important tools in your toolkit as a clinician, and remember, you're now a diagnosing and prescribing clinician as a nurse practitioner. One of the most important tools in your toolkit is knowing how to do a really, really good symptom analysis. So here's an old CARTS mnemonic to remind you of the components. Onset. I can't say this strongly enough. Timing of symptomatology is key. Timing. Exactly when did it start? How many times has it occurred? Location, duration, character, aggravating factors, relieving factors, key. what made it worse, what makes it better, timing and severity. And what I always do, the old CARTS mnemonic doesn't allow me to do this, but I always put timing, timing, timing. Anything that has to do with timing, I always start with that because that will bail you out so often in your clinical practice. You also need to know to recognize normal and abnormal physical exam findings, age appropriate exam in the child. Obviously, that's for the family NPs only. But remember, for the adult gero NPs, your scope of practice starts with the adolescent. And then all of you need to know about normal age-related findings in the older adult. And then, of course, abnormal physical exam findings for commonly encountered problems in primary care setting, not in the acute care setting. Most of you are coming from the acute care setting where people often have failed outpatient treatment for whatever they have, or they're more days into the illness. Next time, for those of you who are, even, for that matter, even in the emergency department, let alone the medical floor or the ICU, next time you get a patient who you're going to admit with pneumonia, ask them how many days they've been sick, if they're able to tell you that, or ask if they were brought in by a family member or a friend or whatever, ask how many days they've been sick. Very often what you're going to hear is, well, been sick for about 2 weeks, been sick for 3 weeks. And now you're seeing a very progressive pneumonia that has caused this person to be so ill, they need to be admitted. What you'll notice in the review course, if you haven't gotten to it yet, with the respiratory part of the program, is we have a case study of a man very well linked up with primary care who has a pneumonia, ends up with a pneumonia. He's only been sick for a couple of days. And that's what you see with people who are linked up well with primary care. And remember, you are about ready to sit for a primary care exam, not an ED exam, not an urgent care exam, a primary care exam. So here's an example. AGNP people, please just bear with us for a moment because I need to make sure I include some PED stuff because probably about 80% of you on this program are family NPs. A 5-year-old healthy child presents with his parent for a well child visit. Note the word healthy. If it says the child's healthy, the child's healthy. There are no parental concerns, and the child is on his growth curve, which has been 50th percentile height, 25th percentile weight. It's not that uncommon for kids around this age to be taller than they are heavier. And you would look at this kid and you wouldn't say, oh my God, this poor child has skin and bones. You would say, no, it's kind of a slender child. Okay, they're perfectly fine. Developmentally on target. Exercise tolerance is reported as excellent, with the parent stating he's the fastest runner on his soccer team. That is gold. That is gold. Because what that is telling you is you've got a kid with great cardiac output who is truly well. Vital signs are normal for age. On cardiac exam, a soft vibratory grade 2/6 systolic murmur is best heard in the left lower sternal border. The murmur decreases in intensity when the child stands and becomes louder when supine, without radiation beyond the precordium. Remember what that means is if it says the murmur does not radiate beyond the precordium, what it's telling you is you can hear it on the chest, but it doesn't go to the axilla, it doesn't go up into the carotids, it doesn't go to the belly. All pulses are full and intact. Which of the following best describes this finding? I bet all of you want to just skip this because you don't like this question, but here we are. A pathologic murmur. B, likely a normal early childhood finding. C, evidence of hypertrophic cardiomyopathy. D, a murmur consistent with aortic stenosis. All right. Well, first of all, let's take a look at the options here. A pathologic murmur. We have, first of all, that might look tempting because you go like, I don't even know what it is. I'm going to consider it pathologic till proven otherwise. But we have an otherwise thriving child here. And the other thing is we know from the height and weight, this is a slender child. Kids this age have chest walls that are, about as thick as a piece of saran wrap. I mean, you could hear everything in there because he's prepubertal. He doesn't have that thicker muscle mass that even a 14-year-old would. Okay. And so you can hear stuff really, really clearly. The fact that the murmur decreases is in intensity when he stands. Supine to stand. Supine, the heart has more blood in it. Many, if not most, murmurs are louder when supine. Stand, the heart gets taller, thinner. There's less blood leaving the heart. The murmur gets softer. Okay. And that's one of the characteristics of a physiologic murmur. Okay. C, evidence of hypertrophic cardiomyopathy. Well, that is going out into like the stratosphere. First of all, an unusual condition in children. He would also have some evidence of his heart being very big. And what we would probably hear from the parent, instead of he is the fastest kid on his soccer team, we would hear from the parent, he loves playing soccer, but he's the kid who's always at the back of the pack when they're running down the soccer field. Okay. He just can't keep up with anyone else. Okay. He has lousy exercise tolerance. The parent might not say he has poor exercise tolerance, but they're going to tell you something like that. Plus, that's just about the murmur of hypertrophic cardiomyopathy is just about the only murmur, whether it's a child or an adult, that gets louder with supine to stand position. And D, a murmur consistent with aortic stenosis. Now, for those of you who have done a good chunk of the review course, who have been with me on these other sessions, one thing that I say over and over and over again is remember who is going to get what. What's the most common reason for aortic stenosis? Aging, calcific aortic valve. So aortic stenosis murmur, we hear in 80-year-olds, 70-year-olds, we don't see in 5-year-olds. Is there something called congenital aortic stenosis? Yes, but that's totally different. The other thing is the murmur of aortic stenosis always radiates to the neck, always. You'll hear the murmur in the aortic region, and then you'll hear the same murmur over the carotids. So the correct answer here is B, likely a normal early childhood finding. This is the characteristics of a physiologic murmur. Okay. So do you see with a question like this, you have to take everything into account that is given to you here. Every word is important. I know that there are people who will say to you things along the lines of, no. What you have to do is, you skip over words. The stem, the story of the question is loaded with information you don't need. So diagnosis, differential diagnosis, this is the process of identifying the most likely condition among two or more with similar symptoms through analysis and comparison of clinical findings. One more time, you want to consider the more common diagnoses in primary care, as well as the more common risk groups. This condition is present in the entire Fitzgerald review course, are all the, shall we say, classic people, excuse me, who will have that condition. So here's a quick and dirty diagnosis drill. This could be on the family or the adult Gero exam. New onset sore throat times 3 days per patient report. Which of the following describes bacterial pharyngitis caused by group A beta hemolytic strep? So a 14-year-old with a sudden onset severe sore throat, intermittent fever, painful swallowing, tolerating liquids well with frontal headache, exudative pharyngitis, and anterior cervical lymphadenopathy. So along here, and usually that lymphadenopathy is super tender too, and a clear chest. or a 40-year-old with gradual onset sore throat, feeling warm at times, without fever, clear nasal discharge, dry cough, lungs without crackles or wheezes, minimal cervical lymphadenopathy, pharyngeal erythema without exudate. Which one of those sounds like a strep throat? Which one of those is a risk group for strep throat? And it is going to be the 14-year-old. Is classic presentation. And the 40-year-old, this is viral syndrome, multi-organ presentation. What do I mean by multi-organ? Nose is running, dry cough, gradual onset sore throat, that type of thing. So that's how you start with your differential on that one. So what I'm going to do with our next session today together is I will go over then plan and evaluation domains. So what I want to do now is remind you NP knowledge equals NP power equals NP board success. And what we're going to do now is turn the questions over to you. This is your time. So let me see what you guys have. Oh, good. You've got 4 questions for me. Excellent. Okay. I didn't do well on my ANCC practice test, so I'm taking my time to learn more. A patient who started on an ACE, when do you request a follow-up? 2 weeks, 6 weeks, 2 months, or 3 months? Okay. First of all, you are unlikely to get a question that specific on boards unless it has something else added to it. Okay. Because that's a factoid question. It is not a clinical decision-making question. So first of all, when I look at a question like that, I say to myself, first of all, very poorly written, very poor. And I trust what you say. I doubt that that was a practice question that would ever be on the ANCC exam, but I suspect you're thinking of taking the ANCC exam. But anyway. So what we have to do is say, okay, why was a person put on an ACE inhibitor? Or for that matter, an ARB? Because, we talk about those 2 different drug classes like 2 sides of the same coin, okay? This is more a big step back question. First of all, it would be an evaluation question because it's evaluating response to care, okay? So the person's already been diagnosed and already treated. And general rule, and I'm going to assume the med was started for hypertension because you didn't mention anything other than that, and that's the most common reason for somebody to go on an ACE inhibitor. Okay, so what do the evidence-based guidelines say? So the American Heart Association / ACC, American College of Cardiology guidelines for best evidence for treating high blood pressure say we see people back in 1 month. What do you notice there? That's not even mentioned there. That's not even mentioned, okay? Because you're telling me 2 weeks, 6 weeks, 2 months, or 3 months. Why 1 month? Because most of these meds take a number of weeks before you see their full clinical effect. If you see somebody back at 2 weeks, which I sometimes do, when somebody came in to see me with sky high blood pressure, but they don't have hypertensive emergency, they have asymptomatic elevated blood pressure. And I happen to know where I practice. Sometimes I make an initial diagnosis of hypertension with somebody who strolls in. They haven't been seen in healthcare for years. Their BP is 180 over 110, that type of thing. I might see that person back in 2 weeks, but the only reason would be is to go over their labs, make sure they picked up their meds, how they're doing on their meds early on. But 2 weeks out, I do not expect that their blood pressure will have gone down all that much. I don't. So the least offensive of the 4 answers you just gave me, 2 weeks, 6 weeks, 2 months, 3 months. They're all incorrect, by the way, every single one of them. This is why practice questions are not a good way to study. The least offensive is 6 weeks. What I suspect is there was something else in the question and the story of the question, the stem, that you are not recalling that might give you a reason to bring somebody back in 2 weeks. Okay. You didn't recall that because you got really focused in on, I've been given 4 numbers. One of these 4 numbers is correct. Actually, none of the 4 numbers are correct. Right. So I hope that that makes sense for you. But the more common scenario would be as follows. It would be something like, you see somebody, you diagnose them with high blood pressure, you start them on meds, and what's the next best step? And it would be 4-week follow-up. And they'll probably throw something else in there, like to check on medication adherence, check on adverse effects, recheck labs. There'll be something along those lines. Okay. Is severe elevated blood pressure greater than 180 over greater than 120? I got a little confused in the number with the live review. It is greater than 180 over greater than 120. I noticed that as I hop between topics on the test, between hematology versus cardiovascular versus respiratory, I seem to forget some questions or information when I come back to the topic. Is this a strategy I'm not using to reduce this from happening? No. And please correct me if I've misinterpreted what you're saying here. The boards are like practice. And I'm going to talk to you all like your family NPs because I think the adult Gero can figure this out. A question on a 5-year-old is followed by a question on a 90-year-old. A question on hypertension is followed by a question on thyroid. A question on thyroid is followed by a question on a newborn. Okay. In other words, it is like a day at clinic. There isn't a cardiac section of the exam and a musculoskeletal ortho section of the exam. No. It bounces around just like clinical practice bounces around. And the idea is, remember, and this comes from chapter 1 of the review course, the exam is a test to evaluate your ability to practice and perform like a safe entry level NP. And it is a test of your walking around information, the information that a safe entry level NP would have up here in the noggin on the hard drive without needing to look things up. That's why you don't get tested on drug doses, because that's lookup information. So there is an expectation that your ability to think clinically is firm enough that what you can do is hop from cardiology to pulmonary to GI to pediatrics without disrupting your decision making. So you know what this is telling you? This is telling you, don't say to yourself, oh my God, then I'm never going to pass boards. This is what it's saying is, I need to work at securing my knowledge base so that I am able to switch gears like a practicing NP is able to do this. And remember, the boards are not based on what you studied in school. They're based on what practicing NPs actually do. Both certifying agencies will tell you that. Now, if I'm drawing Venn diagrams, is there a huge overlap between those two? Absolutely. Absolutely. But there's no particular strategy other than securing your knowledge base. So again, the how, the what, the why. How soon should you add a second blood pressure med if blood pressure is not at goal? Are there other factors that determine, or is it solely based on blood pressure? Okay. Glad you asked this question. Adding a second med, as long as the person has been adhering to med number one, as long as there has been adherence, okay, you add a second med 1 month out after taking the first med consistently. And it is largely based on what the blood pressure is. It is. So let's say when you made the diagnosis of high blood pressure, the person's blood pressure was 160 over 90. All right. And so the general rule is you are not going to squeeze much more than 10, maybe 12 to 15 millimeters of mercury systolic drop out of a single blood pressure medicine. So if somebody started off at 160 over 90, generally, whatever that med was you started the person on is going to bring their blood pressure down to about 150 over 85. Maybe high 140s, maybe. Okay. So what do we know now? We know that blood pressure is still too high, correct? And you saw the person was on it for about 4 weeks, and they tell you, I think there was one day I forgot to take it. That's okay. Well, it's not okay, but you know what I mean. We can accept, if you will, almost perfection, but not full perfection. And then I always raise it with the patient. It's like, you know what I do? Because I like to tell people they're doing great. I'll say, okay, saw somebody 4 weeks ago, they were 160 over 90. I started them on monotherapy. By the way, you can use 2-drug therapy. I'll tell you why I don't do that all that often. So 160 over 90. And I see them back 4 weeks later, and they say to me, and I ask, how you doing with taking the medicine? Tell me how you take the medicine. And they'll say, I take the medicine pretty much every morning. But they'll look down at the floor. I know there was one morning I rushed out to work. I forgot to take it. I'll say, wow, you took it practically every day. Well done. Well done. How can we work together so that there's never a missed day or hardly ever a missed day? So I'll frame it back. First, I don't go like, well, what the heck happened that morning? You missed it. We all have, quote, bad mornings, don't we? Yeah. So I focus on the positive, not the negative. And so now I see them back. Their blood pressure is still not at goal. It was 160 over 90, and it's now 150 over, let's say, 85. I know the goal is less than 130 over less than 80. I do know that. And so then I will add a second medication. Now, let me tell you, I almost hesitate to do this because it's going a little off script. You will notice that when you look at the guidelines, you could potentially have started that person on 2 meds because they're at stage 2 hypertension at 160 over 90. I tend to start with monotherapy and then add on. One of my reasons for that is almost all of the patients that I see do physically demanding work. They work in warehouses, they're in manufacturing, they're in housekeeping, they're home health aides, and this is Eastern Massachusetts. We have a lot of old housing. I have patients who are home health aides that walk up to 4th and sometimes 5th floor walk-up apartments. So, I don't ever want them to be dizzy. So I tend to take a few months bringing the blood pressure down, but just remember, for purposes of the board, that person 160 over 90, you could start them on 2 meds at the same time. And I see somebody that, okay, so I hear you. I'm really sorry to hear that. There's somebody who is on the call today who did take the AANP exam and unfortunately failed it. And so, you know what I want you to do? Can you message Stephanie in the chat box? Or what you can do is email CS like customer service at FHEA.com. And what we want to do is get you into our complimentary remediation. I'm sorry to hear that, but I'll be able to give you lots of tips. How often does an ECG interpretation question come on the AA&P exam? Fairly often there tends to be one, and it will be either recognizing something like atrial fib or a really acute change in the electrocardiogram, like big ST elevation, but they'll also give you this in the context of a person who's in your exam room, diaphoretic crushing chest pain, that type of thing. So first of all, remember, you're being asked questions on interpreting both cardiac rhythms and the 12-lead ECG because it is an expectation of NP practice. So I want you to be super, super, super clear on that. It's not like they're just trying to be mean, right? But here is also what I want to say to you guys. It's one question.
I didn't get that. Could you try again?
I apologize. My phone fell asleep and I was just checking on the phone. And apparently I hit something a little too hard and now Siri is thinking I'm asking it a question. So my apologies. So anyway, so back to the ECG. I teach 12-lead ECG interpretation. I teach cardiac rhythm interpretation. You will need to probably dedicate 6 hours of study for one question. How good a return on investment is that? Awful, awful. Don't bother. However, the workplace will expect you to know how to read a 12-lead ECG and interpret cardiac rhythms. They will. So for your practice, yes. My advice for the boards is don't bother. Spend that 6 hours working on something else that's far more likely to come up on the boards. If you talk to your buddies who are acute care NPs, what they're going to do is tell you, oh, wait a minute, we got tons of chest x-rays, tons of 12-lead ECGs. Yeah, they're acute care NPs. They're not going to get the questions we get. I struggle with heart murmurs. I've completed the review course, but I'm still getting most of the answers wrong. Could you go over a few infant, childhood, and adult murmurs with a test success tip? Okay, I'm going to skip over infant and childhood because truly in infancy, those are highly unlikely to show up on the boards because they're almost always murmurs picked up in early infancy are almost always a result of congenital heart defect. And there's a gestalt of those babies. We see them, they don't feed well. They turn blue around the lips when they're trying to suckle. They'll suckle on the breast or a bottle and they'll go suckle, suckle, suckle. And then they'll break and go, nothing subtle about them. Those aren't going to be on the boards. The childhood murmur, I just went over it with you. Adult murmurs, go back to the section that I put together on cardiac murmurs and look at the Mr. Paz and Ms. Ard mnemonic. And then what I want you to do is give me a little bit more information, not just adult murmurs, but what are you struggling with the adults? Systolic or diastolic? Diastolic murmurs aren't going to show up on your boards. Systolic murmurs in adults. I'll do kind of real quick drill on this. Aortic stenosis will be one of the most common. Okay. Who gets that? Older adults. Systolic murmur radiates to the neck. Why do older adults get this? Their aortic valve gets stenotic because it gets calcific because it's older. Okay. So test success tip is to go back and listen to that whole program over again. Okay. And get rid of the thought that you're going to get infant and childhood murmurs on there above and beyond physiologic. Okay. The other most common, more common, two other more common adult murmurs will be murmur of mitral regurg. Who do you usually see this in? People with big fat left ventricles. So think heart failure, think things along those lines. So in other words, it's not a solo finding, not a solo finding. When you go over that section on honing your cardiac exam one more time, that's part of the review course. I want you to hone in on the fact that every single one of those patients with a heart murmur is a member of the most representative group to have that murmur. Okay, so I want you to remember that. Okay, and then murmur of mitral valve prolapse, generally younger, more slender women, and it's a mid to late systolic murmur, and they're fine. They're right as rain. They're right as rain. Okay, all right. Do you have a review course on research, Medicare, Medicaid? Go over the professional issues part of our review course. That's got everything that you need in it. Regarding BP meds, how soon do we need to check labs after starting the meds? You have to think like a diagnostician now. Tell me which labs and why. Because just to say labs, when you put somebody on a thiazide diuretic, doesn't impact bone marrow or RBC production or WBC production. So we don't even give a thought to doing something like a CBC. Okay. We don't even give a thought to it. But so see how I'm trying to get you to think more narrow, not just labs. Somebody on a thiazide diuretic, however, and or an ACE inhibitor, we need to think about electrolytes, right? So electrolytes, so what do I mean by that? You could have sodium depletion in an older adult on a thiazide diuretic because that's how these work. They work by depleting sodium, and that helps drive down the blood pressure. So general rule, 1 month out. And with the ACE inhibitors, there's a possibility, and ARBs, there's a possibility of hyperkalemia because these are potassium sparing drugs, and we generally recheck 1 month out as well. So it's sodium and potassium, and it's generally just 1 month out, right? But I do want you to really hone in on remembering what it is that you are struggling with, okay? And don't just think general like labs. Labs need to be done. I want you to think, okay, I'm the one that's signing the lab slip, okay? And so, all right, you know what? There are a couple of people on here that are struggling with the boards. Please put your information into Stephanie in the chat box and we can be in touch. What's the mnemonic for heart murmurs again? You know what? I'm not even going to go over it again because it's in your learning material. It's in your learning material. And I fear what's happening is the idea behind these sessions is people would be very well into the review course before they came to these and had their questions developed. It's really clear that many people haven't looked much, or at least haven't looked at a given section of the review course. So you've got that information. I'm going to kick it back to you. All right, we have 5 more minutes. And I've answered all the questions, so let's make good use of this. Come on, you guys. You had all those questions for me earlier, and I apologize. The way this is set up, I can't call on anyone individually. You're going to have to put the question into the Q&A box. And remember, if you put anything into the chat box, you need to move that question over from chat to Q&A. A few things to keep in mind. You folks are sitting for the exam, obviously in 2026. The hypertension guidelines changed a wee bit in fall of 2025. A wee bit. The main thing is that changed are, thankfully, long overdue. The terminology that AHA and ACC use is they are race agnostic. In other words, we're not prioritizing people to be Black or non-Black, which was terminology that has driven me half out of my mind since they published these guidelines in 2017. But now what they're saying is regardless of Black versus non-Black, everyone, the starting meds are ACE inhibitor or ARB, thiazide diuretic, calcium channel blocker. Have a nice day. Priority meds are ACE inhibitors or ARB in the presence of diabetes and or CKD. But other than that, we just use any of those meds, particularly for the initial meds. I will tell you, calcium channel blockers are the most potent of the high blood pressure medications. You're going to get the most rapid blood pressure drop, but not too rapid, and the most potent blood pressure drop with the use of the calcium channel blockers. Okay. All right. This is a question. You have an adolescent taking part of research about sexual behavior. Will you seek consent from both parent and the adolescent? First of all, you are never in 1,000 years going to get that question on the boards. Ever, 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 ever. Okay. That is a big outlier. And the answer to that is it depends. All right. I'm baffled as to, I suspect that came from some practice exam somewhere, but an adolescent to be treated for quote sexual behavior, like in need of contraception, need of treatment of STIs, that type of thing, and your exam room. So like a 16-year-old, okay, those are considered to be medically emancipating conditions, sexual behavior, and therefore they can come in for treatment of those or prevention of them without parental consent. Research is a whole other ballgame, a whole other ballgame. So I don't want to mix those up. It would be, and then it gets into just like, okay, let me give you an example. It's research on PrEP, pre-exposure prophylaxis for sexually active teens to help prevent them from getting HIV. A lot of times those are kids who are medically emancipated. Anyway, you know what? That's such a weedy question that it would really and truly depend on the research protocol. So you're not going to get a question like that on boards. I've been studying for about 6 weeks and feel my walking around studying has gotten better. Good. But when I do a practice quiz, I get lost and overwhelmed by the wide range of language. Okay, don't call it language. You're still working on building your knowledge base. I've had people say to me, oh, to pass boards, I think I need a vocabulary module. No. If you're being tripped up on language and questions, that is telling you you've made a lot of progress in your knowledge base, you're still not there. And so disease process you're unfamiliar with, first of all, I'd be willing to bet you're doing practice quizzes that are not well suited for primary care, okay? Because if you go back to chapter one more time on the top 25 diagnoses seen in primary care, it's right there. Those are the diseases you're going to be tested on the most. So if you're running into exotic conditions that are not seen in primary care, that's one of the follies of doing practice questions, okay? What are the primary cares to evaluate in pregnancy other than issues with the placenta? I'm, in the interest of time, I'm going to kick you back to the care of the person during pregnancy part of the program. It really narrows it down to a handful of things. For reassuring adequate preparation for the exam, would taking a post-test as part of the course and getting 80% or greater high likelihood that you'll pass. I like to hear on our post-test, minimum 80%. I prefer 85% or higher. Okay. Should you take the practice test a couple of times or just once? It really depends on the practice test. It really does. The stuff that you purchase online is often very poor. Okay, and somebody just said they bought some practice tests from one of the certifying bodies. I'm not saying which one. Remember, what they often do when they're selling those questions is they're taking out old questions that are no longer on the exam. Okay. I have one more question I'm going to answer here, and then we need to wrap it up. Prescribing antibiotic, it seems like the common choices we tend to memorize. Expunge the word memorize. Expunge it right now. Conceptualize and know. Are Bactrim, augmented amoxicillin. Cut Bactrim out. Bactrim's hardly ever used anymore. The guidelines seem to get confusing with the fluoroquinolones as a last line antibiotic, but I see this come up frequently as the correct answer for penicillin allergy questions. It's not the correct answer. You're back to, with practice tests, you're looking at practice tests that are not up to current practice, because with penicillin allergy, first of all, I think you all know this, 10% of the adult population will tell you they're penicillin allergic. What percent of people in the general population are actually truly penicillin allergic? Less than 1%. So in the absence of anaphylaxis, and remember what anaphylaxis is, that whole systemic allergic reaction, the angioedema, the hives, the wheezing, sudden onset GI upset, that type of thing, low blood pressure, like life-threatening. In the absence of anaphylaxis, you can use the cephalosporins. And with respiratory tract pathogens, we definitely don't use Bactrim. Definitely. Just expunge that from your memory bank. Okay? Get rid of it. We don't. Because Bactrim has lousy strep pneumo coverage and H flu coverage and Moraxella catarrhalis coverage. So we get rid of that. We do not use azithromycin as a substitute, even in penicillin allergy, because in respiratory tract infection in particular, it will fail with strep pneumo. And that's the most common ABRS, AOM, and COPD exacerbation when it's bacterial organism. Okay. We only go to the fluoroquinolones when our back's against the wall, because in the vast majority of people with penicillin allergy, the cephalosporins can be used safely. And what do they cover? Strep pneumo, H flu, MCAT, and they're stable in the presence of beta-lactamase. So, and the course book doesn't conflict with the questions we ask in the course. But I think what's happening is you're looking at some outdated sources that conflict with the information that's in our course, the Fitzgerald course, and that's why you're getting confused. And you know what? Just my last takeaway on this one, stick to what you have. You have access to this review course. It's proven itself on 180,000 plus NPs, probably, truth be told, closer to 200,000 if we could kind of, if we could kind of chase down everyone who's ever taken it since the dawn of time. And it is best evidence. Okay, thank you. We are all set now. Remember, I'll see you back in 2 weeks. And when we're back in 2 weeks, come with some very focused questions for me, and I'm more than happy to help you out. And we will go over treatment plan and evaluation of treatment in our next session. Thanks so much for being here. And thank you, Stephanie, for holding down the fort. Bye-bye.
Have a good one, Margaret.
Thank you. Take care.
Thanks, you too.